Yes. Hello, everybody. My name is Daphne. I might have contacted with the majority of the people here, but I work in the office at HAE Canada, and I work with organizing an amazing board who works across the country very hard on behalf of the patients in Canada with HAE. So today in the panelist, as panelists, we have Jackie, who is the president of HAE Canada. She's there she is in Winnipeg, and she will be presenting first. And we also have Dr. Ritchie here. So I think the majority of the people on the webcast know Dr. Ritchie, but I have a small little bio that I can read on his behalf. Dr. Ritchie is a hematologist and oncologist, general internist, general researcher, biochemistry researcher, and biobanker. Apart from HAE, Dr. Ritchie has worked in many different fields, including sickle cell disease and congenital vascular disorders, to name but a few. Since 1991, he has been developing innovative comprehensive care and home treatment programs. Dr. Ritchie volunteers for many patient organizations and was one of the founders of the network of rare blood disorder organizations in Canada. So thank you, Dr. Ritchie, for joining us. We really appreciate your time and your expertise today. Thank you. Today, we will start with a presentation by Jackie, and then we'll move on to Dr. Ritchie, where we will follow by some questions that we've already been submitted over the past week. So I can ask those to Dr. Ritchie, and we can have an open discussion. So we'll start with Jackie's presentation. So I will share my screen with everybody.
Introduce Lorraine too.
Oh, sorry. There's Lorraine. Lorraine is, many of you have probably spoken to Lorraine. She's very good at contacting people. So she is the Pacific Area Regional Director. And I don't know if her new assistant is on yet, Tamara. So she will be involved as well. And you see Heather down there at the bottom. There she is, in and out. She works with us, and we are very grateful for her technical expertise today. And she's managing us today online. And these days we're going to be using her a lot. So we'll start with Jackie's presentation. I'm going to share.
And also for Lorraine in her field of study, Lorraine is a psychiatric nurse, and she practiced for 47 years and has just currently retired and has been willing to do this and helping us out.
Yes.
And myself, at HAE Canada, where I worked in healthcare for over 30 years. I worked in emergency, I worked in administration, public health, and I was on a lot of regional, provincial, and national type of appointed roles throughout my career. I still do a few of those. I have been with HAE Canada since, I realize that today, 2011 is how long I've been with HAE Canada when I started. So nice. I think I've met some of you guys already in person when I've been in Edmonton before. Nice to see you guys again.
Yeah, awesome. So I will share my screen. And I want to just say, I hope everything goes well today. It's our first time, so there's a bit of learning curve going on. So just bear with us if something goes wrong.
Everything's just minimized for me all of a sudden. Oh, okay, I get it. So I got it.
Can everybody see my screen?
Yes.
We can do the whole thing.
There we go.
Can you start it at the beginning? Yeah, there we go.
Yeah.
Perfect. Okay, everyone, this won't take too long, so then this way we can get to Dr. Ritchie's, but I just wanted to be able to show you guys what we've been doing over the last year. So I've named this Your Association and You. Our vision is on our website, and we are going to be launching a brand new website design for HAE Day this year. So make sure to look, and you're going to find a very brand new website. Next. This is the presentation for here. Next.
Yep.
This is our HAE Canada team. So this way it's on our website, so you guys know. I'll let you look at the names. These are our different regional directors. Our regional directors are always very busy. Every time we do surveys, we are very good at getting our surveys done, and our regional directors will even call people. Anytime you have any concerns, you can either the HAE Canada office or your regional director. Next. And this is our team. So you see the faces.
Yeah.
Next. These right now are the approved therapies that we have. Acute, we have the Berinert IV plasma-derived C1 inhibitor, the Firazyr we have. Prophylaxis, Cinryze, Haegarda, Takhzyro, and tranexamic acid are approved in Canada. They're through Health Canada. We're just trying to get them available to patients. We're hoping it's going to be soon for the Haegarda and Takhzyro, but we haven't been given a launch date yet, but check the website because we'll have announcements the minute they are. Next. On the horizon, we have BioCryst, which is an oral kallikrein inhibitor, was in phase 3 clinical trials. CSL Behring has phase 2 clinical trials, a monoclonal antibody against factor 12. Ionis phase 1/2 antisense oligonucleotide targeting P kallikrein. Adverum was a assisted gene therapy, was currently on hold, but I've just heard from them recently and we're going to be having a call. So let's hope we have some gene therapy on the horizon. Acute, we have BioCryst also doing a phase 3 clinical trial for an oral kallikrein inhibitor. Calvista was doing phase 2 clinical trials, and hopefully they'll be coming to Canada. Pharvaris, phase 2 for a oral B2 bradykinin receptor antagonist. Attune Pharmaceuticals, and other orals. So hopefully down that pipe, we've been speaking lately to BioCryst, and actually CORD, the Canadian Organization of Rare Disorders, has spoken to them and is going to assist them to get it into Canada because they don't currently have a company in Canada, but CORD can help them out with that. Next. So basically here, what we find is the model for success is that we have to have a patient organization. We have to have a group of very dedicated HAE specialists and physicians, which we are currently very grateful in Canada. It's a very dedicated job, and the ones we have right now are doing a very good job. You need your pharmaceutical companies that are willing to bring the products into Canada, and we're very fortunate that the two sponsors that we mainly have, CSL Behring and Takeda, are very good at bringing their products to Canada right when other countries are getting it. Initially when I started, and just prior, we were like 20 years behind in Canada, and then now we're right there when everybody else is getting it in other countries, which is very nice. And also I find the Orphan Disease Organization, I feel CORD is always there to help us and anything we ever ask of them. Next. Next.
Yeah, our global responsibility. Okay.
There's our global responsibility. I'll let you guys kind of read and see what that is. What I'll explain here is that I have a monthly call with Tony Castaldo, who's the HAEI president and HAEA president, and will help and give me the information that we need. He'll also encourage people to come to Canada for clinical trials and help to get the products through. He'll also connect me to all the other presidents from all the other organizations. So we all help each other out to get what we need through. And since we started doing that, that's made our roles and the amount of work a lot easier. Next. See, this was at the Quebec update. Here we had Tony Castaldo that came to speak. Next. HAI Connect is another thing that they're doing globally, which we haven't joined yet. We're kind of looking to see, and we're listening to the physicians for a registry for the physicians. Ourselves, our database is only in Canada. And that's what we have with events management, and it's very properly managed, it's very secure, and we're very comfortable with what we're doing, and the privacy of your information is very good. And the one leading for the registry for the physicians is Dr. Ritchie. He's on the global panel and considered a global expert for that. So you're very lucky to have him on that. Next. Global Magazine, if you watch our website, you're going to see that we always have a section for Canada. And we always post that on our website, just the Canadian section of it. Next. See, that's the example. That's our HAE Canada newsletter. And the one that we just put up is when we were in Vienna, we had won the global walk. Canada had done well. And just to let you know, again, that's what we're hoping to announce on HAE Day, because right now we are currently in the lead for the global walk once again. Next. And the HAE youngsters, that's another group. We sent youngsters to the different workshops on both occasions to Atlanta. And we had sent one out in Europe prior, and we are going to be ready to start offering some of the HAE youngsters. And I'll let you do the next slide, Daphne. Next. Yeah, that's our child youth. That's when we're in Vienna. We're going to be having the Brady Club that's going to be coming. They're allowing us to share, and we're making it Canadian. So then this way we have our child youth associates, and we're getting all the different resources from these. So look on HAE Day to our website and see what's coming. Next. So one of the main things we find is that we need to have a seat at the table for local decisions. We also need real world data, and that's where you guys filling out your surveys is giving us that, and that's why we're getting the products in Canada. The last survey, we had 90% of everyone in the West filled out the surveys, and that in a week's time, we managed to get a very good patient submission for Takhzyro, and we got a positive with Caddis. So thank you very much for filling that out quite quickly within a week. Next. And we partnered with Yang Medicine and Red Maple Trial, so that way we could present abstracts and posters to our national report card. And this way, it made us quite noticed internationally. And now that's how we've gotten such a seat at the table internationally because of it. Next.
Yeah.
Next. It's still the same. Oh, that was us presenting in Vienna. We were presenting the abstracts, and they're in Lisbon. And in Vienna, we were the ones that had the most people around and the most questions. And actually, Dr. Marco Ciccardi was quite interested in our abstracts. So there we got a lot of traffic comes in. Next. And in Portugal, we presented. Next.
Sorry. Yep.
You can see we've been quite busy. And then we also presented in Marburg, Germany at the C1. And can you put the slide before? It says the name of the conference, Daphne. Yeah. There. It was 40 years. It was 40 years.
Sorry.
40 years of C1 inhibitor therapy, replacing the missing gene. And that's us there in Marburg. And we were one of the only countries that got to present our work. So we were quite happy to be there. Next. And there was at CSACI in Montreal when we presented. And unfortunately, I couldn't be there to present. So fortunately, Daphne and Tina. Tina on the right is the Vice President of HAE Canada. In the middle is Dr. Yang. He took my place to present with Daphne and Tina. Next. And web hosting currently is by Heather Dow, and Events Management Plus, that's Heather who you just met. And we're going to be doing our web hosting with HAI coming up. But Heather is the one who protects all our data, our membership, and our emails, and all of this. So she's got a very secure server that's in Canada, and she's very good at doing that. And she's the one who sends you all the time to do the surveys and everything. And we're very grateful for Heather and all her work and her team.
Yeah.
Next. There, we did some advocacy. We did some meetings with Canadian Blood Services on the left, and then on the right, that was with the provincial ministries. That was in Newfoundland. That's the last meeting I had in the provinces. It took 5 years to get the Icatibant Fierzer coast to coast, but we were happy to say we got it coast to coast, so every type 1 and 2 got access. And now coming up with the Icatibant and the Fierzer, those who are HAE with normal C1, if you had some free doses initially, you can ask again, because some people with pictures they're managing to get some Icatibant Fierzer, or at least for myself, I know I pay $3,200 a dose because I'm an HA with normal C1, and now we might have a chance to not have to pay as high a price. Next. We've partnered, like I said, with CORD, and this was a Canadian Organization for Rare Disorders, and this is us doing some lobbying at Parliament Hill. Next. And there we had the last Edmonton patient update, and we had a nice picture with Lorraine and Dr. Ritchie. Next. Projects, we also did a quality of life survey, which you guys were very good at filling out with Chain. And there's going to be some data that's going to be presented. It was supposed to be presented at the next global, but unfortunately with COVID-19, it's not there. But there's going to be some virtual ones, and we're going to be seeing that data presented soon. Next. And there we went to the CAIF Gala at CSL. And this is the CSL table. That's one of our sponsors. And here you have a lot of their staff. And it's very nice to work with them, and they're very good with us. This is the Takeda staff, and the same thing. We had Tina and Daphne. I couldn't make it, and really nice for us to be at the tables. We're always well treated with our sponsors.
Yeah.
Next. There for the engagement, we tend to have somebody going everywhere. Whoever's closest to go. Here we had someone in Atlantic Canada that was presenting a table, and we'll get a booth. And that's our Atlantic Regional Director and her daughter. And at the same time, do the next slide, we had somebody in Ontario that was presenting. That's Daphne and Tina. They were at the CSACI. And then the next slide, at the same time, we had our Pacific director that was at these foundation fundraisers. So we will often have somebody from HAE Canada presenting from coast to coast somewhere in the same month, so which is nice. Next. And this was HAE Engagement, our virtual walk. We had a picture because we had Daphne took a picture in Ottawa with the CSL Bearing team, and Tina took a picture with Takeda in Toronto for the walk. And we have both these sponsors are currently putting their steps in our virtual walk right now. Next. And there you go, you guys, look at this. This is where we are at. So all those who are joining the virtual walk, this is where we are. Canada, we're in the lead. And we've got only a couple of weeks left. So if any of you guys want to join, you look at this link, you go for a walk, clock in your steps, put it under Canada. Thank you. And here was a picture of us doing a walk when we were in Vienna. And I'd like to take a few moments just for a thank you. Here I'm pictured on the right with Joseph Andolfato, and unfortunately we have lost him since. He's from Bering, and we are looking, and we're starting a foundation for HAE Canada, and it's going to be the CASP Foundation in memory of Joseph Andolfato. And his wife and his daughter are going to be on the foundation with us. Next. And here we are. This is your own Dr. Ritchie. We were there, and he's always at all the global conferences. It's a wonder to have him there. He's always on the panel, and you guys are very fortunate to have him so active internationally. And this was us in Canada. We won the walk. We launched our child and youth, and I'll see the next slide, and then we'll show you a video. And this is Dr. Marco Ciccardi. He was also someone in Italy. Actually, Lorraine and I were supposed to be in Milan right now, and he had invited us to visit his clinic, and unfortunately, we have lost him also. Next. And the global conference, and some of you guys had applied for the travel grants and unfortunately got canceled. So if you were an HAE Canada member, and when it comes, check our website, check our social media, you can click on our website, and when the next conference comes, you can apply for a travel grant and your flight will be covered to go to the global conference. And this is a wonderful conference. We have about 1,000 patients and caregivers from all around the world who comes. And next, I would like to show you the video, because we were in it, start and finish, because they took a picture of us with the child youth, and Dr. Ritchie's on that with us. So I'll let Heather show that video.
Everywhere we go, everywhere we go, oh, oh, oh. Everywhere we go, everywhere we go, oh, oh, oh. Everywhere we go, everywhere we go. The sunshine. Everywhere we go, everywhere we go. The sunshine. Everywhere we go, everywhere we go. Take a road and a road to the open air. Anytime and a place, and I'll meet you there. Blow back those clouds, and you and I will bring the sunshine. Take a chance to throw away your cares. Take a bus or a plane, it don't matter where. This day is ours, and you and I will bring the sunshine. Oh yeah. Everywhere we go, everywhere we go. Oh, oh. Everywhere we go, 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 everywhere we go. We bring the sunshine.
So if you guys noticed the last picture, it started with that picture too. It was all of the Canadians in their red shirts that we had, and Dr. Ritchie was with us. So they started the video with all of us, and we ended it. So if you guys ever have a chance to apply for that grant, please do. It's quite an event to go to. Now I'll let Daphne introduce for Dr. Ritchie to present. Thank you.
Yes. Oh, I gave a blurb on Dr. Ritchie earlier, but if Dr. Ritchie, if you're ready to do you said you were thinking of doing your presentation. If you're wanting to share it now, that would be wonderful.
Sure, I'm happy to do that. I had to mute my screen because my wife was making noise in the background. She always complains if I walk in on her Zoom yoga class. She was getting me back.
Yeah.
Okay. So yeah, I'll show a couple of slides. They always say an expert is somebody from out of town with slides. And I guess if you're going to talk as an expert, you have to have the slides to do it. Just give me a second.
Yours are hard.
It's all
And while you're getting organized, I'll just remind the attendees, if you want to be moved up to a panelist so that you can be seen and heard, just let us know in the chat box with a little note identifying yourself, and we will move you up so that we can see and hear you.
okay. This is a picture of me on the left. with my clinic nurse. This is actually a picture from Banff with the Banff Springs Hotel in the background. And just to remind everybody of our beautiful Rocky Mountains. We have a program, a comprehensive care program that started out managing bleeding disorders. Well, in fact, it started out managing hemophilia, and it had, I think, 60 patients at the time. And gradually over the last 20 years or 30 years now, I guess, I've expanded that to include all bleeding disorders. So we now have over 1,000 different bleeding disorder patients. And we have about 800 patients with rare blood disorders. Actually, if you include our hemoglobinopathy clinic, that's probably close to 1,000 as well. So we've gone from a pokey little clinic of 60 patients to a clinic of about 2,000 patients. And one of our nursing directors told us we couldn't be called the Rare Blood Disorder Clinic about 6 months ago, that the Rare Blood Disorder Clinic really was under the Dr. John Akabudu Center for Bleeding Disorders. And you know, you can't fight City Hall, and nursing administrators, they're even harder to fight. So we actually changed the name, and it's now the Dr. John Akabudu Center for Rare Blood Disorder, blood disorders and bleeding disorders. And Dr. Akabudu, most of you won't know, he was a pediatric hematologist who was involved in setting up the bleeding disorder clinic, but was also heavily involved in the treatment of hemoglobinopathies and treated some HAE patients, and collaborated with Dr. Henry Pabst in the treatment of immunodeficiency patients. So it made sense to name the clinic after him. Just show my next slide if I can. And you know, this is just a picture of angioedema patients off the internet, and no point in showing you this because you all know what that's all about. And this is a picture of another patient on the right with hereditary angioedema due to C1 inhibitor deficiency. And basically what they do is they have a normal mouse on the left and a mouse with the C1 inhibitor knockout on the right. And they inject some dye in the tail. You can see the fingers holding the tail back here. They inject a blue dye that if there's angioedema, it leaks into the tissues. And then they put a bit of mustard oil, which can induce angioedema, on the ear of the normal mouse and the mouse with angioedema. And of course, it makes local angioedema, which shows up as a blue color. But because the mustard oil is quite volatile, it affects their nose and their feet as well. And so what we have down here is a picture of the feet of different mice in the same basic experiment. This being a normal mouse, this being a mouse with C1 inhibitor knockout, and this other mouse over here has both the C1 inhibitor knockout, but also a knockout of the bradykinin receptor. And basically what that tells us is if you knock out the C1 inhibitor gene, you don't have any C1 inhibitor and you get angioedema. If you also knock out the bradykinin receptor, you don't get angioedema anymore. So it tells us that it's working through bradykinin. So that was our original understanding of HAE, and life used to be good. When I started doing HAE 20 years ago, there was only two types of angioedema. There was hereditary angioedema due to C1 inhibitor deficiency, and there was allergic angioedema. And we thought life was simple, and so it made setting up the clinic easy. I could treat the C1 inhibitor deficiency patients with C1 inhibitor, and the other patients, I told them they all must have allergy and should go see an allergist. Of course, over the last 20 years now, we've now come to understand that there's other types of angioedema that are that involve the bradykinin pathway. Some of them are hereditary, some of them are not obviously hereditary, and so we're in the setting of trying to identify those patients and find tools to do that. and figure out how best to treat them. And I know many of the people online today are particularly interested in this disorder. So back in 2009 now, that's 11 years ago, but it seems like only yesterday to me. But there was a publication by Konrad Bork, who's an HAE treater in Germany. And Konrad is a wonderful guy. He's in his 70s. And like Marco Ciccardi, is really one of the godfathers of angioedema treatment. And basically, he'd been following patients for a very long time and had these great lists of patients all on paper. I tried to tell him he should be putting it in a database, and he said, yes, he'll get around to that sometime. But everything was done on paper, and he identified these families that clearly had angioedema that was not typical of an allergy, and that didn't respond to an allergy type treatment, and wasn't associated with hives and things like that, and it ran in families. So it was genetic, clearly genetic. And to make a long story short, he did some genome-wide analysis and came up with this mutation in the factor 12 gene. And that's now widely known, and people have looked for it, but it seems to be in very specific populations and not common in North America. But it gave sort of an incentive to Konrad Bork and to others to look for other causes. And these were reviewed by Bruce Seurat in the Journal of Clinical Allergy and Immunology back in 2018. Again, that's now 2 years ago, but I keep thinking of this paper as being just a month or two ago. I guess I'm showing my age. But anyway, what he reviewed, this was a review paper, was the factor 12 mutations, which we call a gain of function mutation. So normally when we think of mutations in genes in man, we think of them knocking out the function of the gene. But in fact, in some genes, a mutation will actually make it more active. And that's what's thought to have happened with the factor 12 mutation. Subsequently, somebody published a mutation in the plasminogen, that's supposed to be plasminogen, not plasminogen receptor. Another one in a gene for angiopoietin 1. Angiopoietin 1 is a growth factor for blood vessels, but it also has an impact on angioedema. And finally, Konrad Bork found another mutation in kininogen 1 gene, which affects how bradykinin is generated. So we now have 5 different types of angioedema, which are hereditary. So we look for these in people where there is a family history, because then we can be more certain that we're going to find a genetic cause. When I say we look at them, we have the ability to look at them, but it's been challenging because to look at all 5, we should really be doing whole genome sequencing. And that's something that people have shied away from, not for a good reason. It used to be because it was too expensive. The first genome sequence was generated around 2000, so over 20 years ago. And at the time, it identified 3 billion nucleotides, and it cost $1 billion to do it. So very expensive. But the technologies in genome sequencing have improved, and we're now down to, I think the latest I saw was $600 US, which is about $800 Canadian. And to just put that in context, if we look for these mutations in any one of these genes right now, to do that each costs about $1,000. Whereas the full genome sequencing, which would look at all these things, probably costs about $600 US, about $800 Canadian. So it's not a money thing at all, but there is sort of a cultural bias against genome sequencing, and part of it is based on what I would call the Statue of Liberty problem. And the reason I call it the Statue of Liberty problem is I have 3 children, 3 boys, no longer children, all grown men, very nice, wonderful grown men. But when they were kids, they used to say to me, you know, I'd say something, they say, Dad, yeah, but what about this? And what about that? And they'd come up with all kinds of scenarios why what I was saying couldn't possibly be right. And my response was, yeah, but what if the Statue of Liberty were to fall on your head? I said, it's not likely, you living in Edmonton, that that's going to happen. So that was sort of a made up bias against whatever I was suggesting. And I think the full genome sequencing has the same made up biases. So, and it's something that I'm hoping this COVID crisis will change. I think there's an opportunity now to change the way we do things and the way the world works. And I'm hopeful that one of those changes will be more ready access to genome sequencing. But let me tell you the criticisms and what my thinking about them is. The criticism is that when you sequence 3 billion nucleotides, you're going to find lots and lots and lots of differences, many of which we currently don't understand. But we might find mutations that are known to cause diseases completely separate from the ones we're looking at. And the problem that people see is that is really twofold. One is we might tell people they're predisposed to a disease for which they won't be able to get insurance. They won't be able to get life insurance or disability insurance. And I don't think that's true. I think if you look at the entire population of the world, there's no people in the world with the same genome sequences. The possibilities of the sequences are so great that there's not only no people in the world with the same sequence, there are no people in the history of the world who've ever had the same DNA sequence. So what that means is we're all different. And in 3 billion nucleotides, I think you'll find we're all predisposed to something. And if that's the case, then there is no future for the insurance industry. And of course, the insurance industry sees a future for itself. So there's no way they're going to stop insuring people with a genetic predisposition to some disease or other. And I think the way the world will move is that perhaps in the future, if you find you're predisposed to a genetic disease, that maybe private insurance won't cover you for life insurance or for disability insurance, but maybe that's something that should fall on government. Just as in Canada, you know, if you have diabetes or something else which is partially genetic, you get treated through the public health system. And so I think that's the way things will happen in the future, and insurance will move back towards covering more things like acts of nature, floods and fires and burglaries and car accidents and stuff like that. So I don't see the insurance problem as being a real problem, and I think we'll work through it. The second problem people have made up, and again, I think this is a Statue of Liberty problem, is that what if we tell you you're predisposed to something and you didn't want to know that? And that's a problem that people commonly use as a reason not to do full genome sequencing. And I have a different take on this because I lived through the era of HIV and hepatitis C in bleeding disorder population, where many of those patients were infected with HIV and hepatitis C, and many of them subsequently died. So huge problem in that population. In the early days, when testing started to become available and we didn't understand how good the tests were, and what they really meant. There were studies done in which we identified patients who had antibodies to HIV, for instance. We didn't know what that meant. We didn't know if that meant they'd been exposed but might have been cured or gotten over it themselves, or if they were still infectious. So some of the investigators chose not to tell the patients because it was potentially bad news and they didn't know what it meant. The Canadian Hemophilia Society came back and said, well, you can't not share information. People need to know. And if they had known, they might not have infected their spouses and others. And so they came up with this idea that people do need to know good news, bad news. And so, so that's what I believe, that people do really need to know bad news, even if it's genetic news. The other part of that is critics say, well, what if we tell you you're predisposed to a disease that has no treatment? And my response to that is, if I were to find out I was predisposed to a genetic disease that didn't have any treatment, the first thing I would do, and I do this for all my patients as well, is I go to a clinical trial site called clinicaltrials.gov, G-O-V, which is a US clinical trial site. And I would put in that disease and I would look for all the clinical trials going on with that disease. And I would look at them, look at the summary, see if it was something I was interested in, and I would call the center doing the trial and find out if I could get involved. And so an example is Huntington's chorea. Huntington's chorea is a rare genetic disease which has been uniformly fatal. And everyone says, well, I wouldn't want to know that I had predisposition to Huntington's disease. And the answer to that is there is, I think, 300 studies ongoing in Huntington's disease right now. And there has been very hopeful results in treatments, some of which are given into lumbar puncture injections and things like that. And if you had the genetic predisposition to that, then you'd probably want to know early and not wait until you had an irreversible form of the disease. You'd probably want to try treatment early to see if you could prevent the development of the disease or prevent the progression of the disease. And the same thing happens with hereditary angioedema. My friend Conrad Bork did another paper in which he looked at people who were in families with hereditary HAE but had not been diagnosed with HAE to look at causes of death. And what he found was there was a huge excess of death from angioedema affecting the airway in patients from families with HAE who hadn't been diagnosed. And, you know, if you think about that, that's just ridiculous that somebody might have HAE, come from a family with HAE and not get the diagnosis. Because if they got their first attack when they're 40 or 50 or whatever years old, and didn't know what it was and didn't think about it and hadn't seen a doctor, hadn't been told to go to hospital if they had treatment, then they might die from their airway obstruction. And certainly that's what Conrad showed in that paper, that there was a huge excess of death from angioedema in undiagnosed people. So all of this goes back to this idea that we should be doing much more genome sequencing. If you don't want to find out if you're predisposed to Huntington's disease, don't get the test. But if you're like most of us and realize that life is a one-way trip, we're all going to get something and all going to die at one stage. And the more you know about yourself, the better prepared you are and the better able you are to try and prevent development and progression of those disorders. So two arguments about doing whole genome sequencing. One is about insurance, which I think is bogus, and one is that people might not want to know, and I think that's pretty much bogus for most people as well. So we should be doing more full genome sequencing, and just in the last couple of months, I found a way to get that done and I'm working with one of the geneticists in Edmonton to try and get that done. So that's hereditary angioedema, including the type 3 angioedemas in which it's not due to C1 inhibitor deficiency, but one of these other mutations. And there's probably more mutations to come. And the last thing I really want to talk about, well, I'm not going to show you this picture. Well, I'm not going to go into any great detail. It's just a biochemical pathway picture showing the development of bradykinin down here and all the places that C1 inhibitor inhibits, including over here. I can't see this on my screen, but factor 12, plasminogen, kallikrein, all of which have been shown to be affected by mutations that lead to hereditary angioedema. There is another group of patients, though, which we struggle with, who don't have a family history, and we call those idiopathic angioedema or chronic spontaneous angioedema, CSU. And I'm telling you the name of this because some of you will have these disorders and will realize we've stopped calling them or calling you type 3 and started calling you idiopathic angioedema. And that's because there's no family history. Like the type 1, 2, and 3s, there's no hives typically. There's no response to allergy treatment, but there is response to bradykinin pathway treatments, which Jackie has talked a little bit about, but also include progesterone treatments as well. So those are a struggle. There are efforts to bring clinical trials with some of the typical C1 inhibitor pathway treatments, and those are ongoing, and we hope to take part in them when they happen in the future. And I think at this point, I'll just stop for a little while to ask if there's any questions. I'd also like to talk briefly about COVID-19 after that, though.
Okay. I have some questions that have been submitted already, and they do touch upon COVID, so it will all be related. The first question was, are there any changes planned for how plasma products will be distributed?
Yeah, that's an excellent question, and I'm going to answer that more broadly. Firstly, by saying that as part of our response in Edmonton to COVID, and we actually haven't had much COVID-19 in Edmonton, but part of our response has been to try and get all patients who come to hospital for treatment to get them off hospital-based treatment and get them treating at home. So in Edmonton, we really pioneered the use of home treatment with C1 inhibitor, but we're pushing other patients who might have been a bit reluctant to go on that. And also in the areas of immunodeficiency where many patients still are taking intravenous immunoglobulin, we're pushing them onto home treatment with subcutaneous immunoglobulin. So that's the first step. The second step is to minimize the exposure to hospitals. We have said that everyone in Canada should be getting at least 3 months supply at any one time, so they only have to come in 4 times a year. And although we've been doing that in Edmonton for much of the last 20 years, in fact, in the rest of Canada, they've only been giving out 1 month or so of treatment at a time. And so, so the rest of Canada has now moved to where we are, and we're pushing on the system to see if we can release 4 months of treatment at a time. And there is some pushback, but I think we'll probably get over that. And, but really the question was, is there a different way to get your C1 inhibitor? And the Network of Rare Blood Disorder Organizations under David Page, and who's, I think, the executive director of that group, and also the executive director of Canadian Hemophilia Society, has been pushing hard on Canadian Blood Services and the provincial ministries of health to develop a system of home delivery. There is a system like that in Quebec. It doesn't actually function very well, but at least it's up and running. And surprisingly, that's moved forwards, and you have to stay tuned. But I think that may well happen within the year. So that may all change. Now you might say, well, if I don't go to hospital where the COVID-19 seems to be concentrated, then I'm less likely to get exposed. But remember, if you're getting packages delivered to you, the risky bit is not what's inside the package necessarily, but the number of people that have handled that package. And really you should be spraying it down with either 10% or 1 in 10 dilution of bleach, or 70% ethanol, or some isopropanol or something, because the risk is really from who might have handled that package or sneezed on it or coughed on it. And that's where the risk is, not in the actual virals themselves. So getting home delivery is probably going to be better, but it's not entirely risk-free. So that's a long answer to a pretty short question.
Thank you. Second question, are there any anticipated supply issues with any of the HAE meds, and what are the plans in case of shortages?
Right. So I've been in touch with the companies that produce these blood products, and they are saying that the plasma supply may be at risk in the future. And starting about a month and a half, 2 months ago, they started to say, well, any impact from plasma donations wouldn't be felt for 8 to 9 months. So the suggestion is that 8 to 9 months from now, there might be a shortage of plasma products, whether they're C1 inhibitor or antibodies, immunoglobulin, or blood clotting factors. That may happen in 8 to 9 months. But because of that, Canadian Blood Services and other producers of these blood products have really ramped up and gone after their donors to say, hey, I know these are tough times, but we really need you to donate. And so far in Canada, we have not seen a decrease in blood donation. And in fact, the blood's as good as it's ever been. And in fact, there's lots and lots of blood because the use has gone down as we've stopped doing elective surgeries and things like that. So while it's possible there may be shortages, it's a long ways off for now. And in the meantime, of course, we have all these new treatments, Jackie alluded to them, that are not dependent on plasma donations. And so we're hopeful we'll get through all this without any problems at all.
Yes, exactly. And that sort of relates to how, what about the availability for Takhzyro for HAE patients right now?
Well, Takhzyro is the monoclonal antibody against kallikrein, and it's produced in a factory. And unlike the meat packing industry and the meat packing factory, there's not many people in those factories. It's mostly automated, so it's very unlikely to be shut down by the factory workers becoming unwell. So I don't see in the near future any problems with the production of Takhzyro or any of the upcoming products as well. I should also mention that there's pretty good evidence that even though COVID-19 can be detected on occasion in the blood, that transfusion of blood from patients who were subsequently found to be COVID-19 positive did not result in transmission of COVID-19. In other words, you don't get COVID-19 from blood transfusions. It doesn't seem possible. You can never say never, but it doesn't seem likely at the current time. And certainly all the plasma products we use are heavily treated with antiviral treatments like pasteurization and solvents and detergents and nanofiltration. So I think the plasma products will always be safe. But Takhzyro and the new factor 12 antibody coming from CSL Behring, I think there'll be abundant of those products. It would just be a question of figuring out how we're going to pay for them. And that's where groups like yours, patient organizations, really have to be going after government and Canadian Blood Service services to try and make those products available.
Yeah, absolutely. Next question that we had was, what do we know about how HAE patients do with COVID-19 specifically?
Yeah, that's a really good question, and I haven't seen anything on COVID-19 in HAE patients. I'm sure there have been HAE patients affected, but I haven't seen anything published. We believe that it may be that patients with HAE are more severely affected. And so our strategy has been to try and convince our patients to follow all the social distancing recommendations to try not to get COVID-19. But we're worried that they may get sicker, but we're not certain of that. Now, just yesterday, I heard that Takeda has discovered that the use of icatibant, which is the small molecule inhibitor of the bradykinin receptor, has been shown to be of benefit in Italy for patients with severe COVID-19. And based on that, my understanding is, and again, this is third-hand information, and I've not been able to find out if it's true, but that Takeda is looking at doing studies on the use of Takhzyro in severely affected COVID-19 patients. And that makes a lot of sense because what we see in the lungs of severely affected COVID-19 patients is they get edema, and they get fluid building up in the tissues themselves, which pushes the blood vessels away from their exposure to oxygen in the little air sacs, which we call alveoli. So as you get edema in the lungs, the transmission of oxygen is not so good. And as well, the little alveoli can fill with fluids. And so this, in many ways, is like angioedema in the lungs. And it's thought that bradykinin levels are very high in patients with angioedema, and that blocking that effect may help. And there's preliminary evidence, apparently, that that's the case. So we may see Takhzyro being used in severely affected COVID-19 patients. I think if that happens, I don't think that will be a concern for the availability of Takhzyro for treating HAE, because it'll be weeks, if not months, before the company could get approval to use that drug through the regulators. And so during that time, I expect that Takeda will ramp up the production of Takhzyro, which they can do pretty easily. Unlike purifying blood products, where you have to make sure the donors are available and healthy and all that sort of thing. With Takhzyro, it's all done in tissue culture in a factory, and it's very easy to ramp that up if necessary. Again, a long answer to a short question.
No, that's great. So can HAE patients access Takhzyro now?
The answer is yes. We have two patients in Edmonton who were treated with Takhzyro as part of a clinical trial, and then have been given access to a supply of Takhzyro to continue with on their treatment. So that's actually happening for a couple of our patients. I believe there are a few patients in Canada who, through exceptional access programs, have gotten access to Takhzyro. Right now, Takeda, who produces Takhzyro, is wrestling with Canadian Blood Services and provincial governments to figure out how this drug will be distributed. The governments and CBS made a decision that this was not a blood product and so shouldn't be provided through the blood system. I think that's a bad result, and I think HAE Canada should be pushing hard on the provinces and on Canadian Blood Services to reverse that decision. And I think you guys should be at every open board meeting, presenting and talking to CBS about. CBS has already decided to supply another monoclonal antibody that's used in treatment of bleeding disorders in patients with factor VIII inhibitors. And so it's not unprecedented for them to supply that. And I think if they do, it will be much more accessible for patients with HAE. So, so you guys should keep pushing for that.
We are indeed. So can patients access HAEGARDA now?
I don't think a decision's been made about that. At least I haven't been told about one. And that's an interesting question. So for those of you that don't know, HAEGARDA is a C1 inhibitor, but in a much more concentrated form so that it can be given subcutaneous for prophylactic use. Having said that, that concentrated form of C1 inhibitor has actually been available in Canada for about 5 years now. And it was licensed for intravenous use, but we and some other treaters have been using it subcutaneously. So something that's very much like HAEGARDA is already available and should be available and can be used for subcutaneous use as well as intravenous use. As for the actual HAEGARDA product itself, my understanding from CSL Behring is that they priced it to be very competitive. So usually at this point, price is the main issue in getting those products available. So I think everyone's busy with COVID-19, but I wouldn't be surprised if the HAEGARDA gets approved and made available reasonably soon.
Next question we received, it says Berinert injection. How safe is the plasma from COVID-19? However, you touched on that.
Yeah, I think I touched on that. I think, you know, even with products like whole blood and packed red blood cells and plasma that we use all the time, there's been no described transmission of COVID-19 in those products. And although COVID-19 is very infectious, it's not a very hardy virus, and it's very easy to get rid of it with, you know, soap and water with 70% ethanol or 1 in 10 dilution of bleach. It kills it right away. And although I haven't seen any publications on studies to look if added COVID can be cleared from the plasma preparations, I think the use of nanofiltration and pasteurization and solvent and detergent treatment is so robust that a wimpy virus like COVID-19 would not survive. So I think the plasma product supply is safe from COVID-19.
Good. And the final question we received last week was, is anything new happening with treatments for type 3 for normal C1?
Right, and I think, you know, most of us in the angioedema business believe that type 3 and also the idiopathic HAEs are all due to, or mostly due to problems in the bradykinin pathway. And so using bradykinin type treatments is the best way to go. The problem is that these treatments have been supplied, apart from C1 inhibitor, which works in some patients. The other products have been supplied through pharmacies, and because they're expensive, pharmacies have not wanted to support the use of them. So insurance companies have not agreed to off-label use of drugs, and that's interesting because we use other drugs off-label all the time. If you look at most antibiotic use, much of it is off-label. One of the common drugs for treatment of atrial fibrillation is a beta blocker drug called bisoprolol, and it's the most commonly used drug for treating atrial fibrillation. Never been licensed for that use, but is the commonest drug used. There are two organizations, the Canadian Senate and CADA, the Canadian Agency for Drug and Therapeutic Assessments, and both of those have said that there are no problems with off-label use of drugs and they should be permitted. So the fact that insurance companies and governments don't want to pay for these drugs is not because of the off-label use, because that's clearly okay. It's because of the cost.
Right.
And again, this goes back to the fact that products are easier to get through the blood system, because the cost of C1 inhibitor for 1,500 units is the same as the cost of one dose of icatibant. And so the price is equivalent, but because one is provided by the blood system, the other by pharmacies and insurance companies, the access is hugely different. Again, something that I think HAE Canada should be getting involved in, pushing on insurance companies, pushing on public insurance, and that sort of thing.
Yes, indeed. That was it for what was submitted during the week. And we do have, I have seen a couple come in during the comment section. Let's see.
Maybe while you're looking at those, I'll just speak briefly about COVID-19. So
Yep.
I'm involved with some of the COVID-19 research here in Edmonton. And, you know, Edmonton hasn't been badly hit. Calgary had 3 or 4 times as many cases as we did in Edmonton. But our province, like other places in the world, is talking about gradually opening up. I think in Canada, we're trying to be a bit more cautious than some places like the US. But we're still talking about opening schools so that kids can finish their school years, opening up golf courses. We opened up the golf courses on Monday of this week, and some other things. And I think they're not opening up completely. Everyone's talking about social distancing. But I think what we will see is that the curve in Canada has been flattened, which doesn't mean people will stop getting COVID. It's just that they're going to get COVID-19 over a much longer time period. So the key to this is, if we believe that patients with angioedema might do worse if they get COVID-19 infection, then it's really important to avoid getting COVID-19. And there are some pretty straightforward ways to do this. It's thought that most of the transmission is through droplets, and although it's possible to inhale those droplets, and it's probably worth wearing a mask, the real transmission is by people picking it up on their hands and then touching their faces and transmitting it to themselves. And so here is the thing. Many of us, when we were younger, were told that we should always be washing our hands. We definitely should be washing our hands before we eat dinner. And that's really key to preventing transmission, is use of hand washing and hand sanitizer. There's been a real effort within hospitals and other health institutions to try and get people to be better at hand washing, and it's worked, but it's certainly worked hugely better since COVID-19's happened. And what I would stress to anyone with HAE is that wash your hands all the time. If you get a package in, whether the mail or whatever, consider it might be contaminated and try and sterilize it, either with a spray of 70% ethanol or some other support. I think that's a very, very sensible thing to do. since we've been on lockdown in Edmonton, I've still been able to work, but I've been spending a lot more time at home. And I've been involved with retail therapy through Amazon. So we're getting lots of packages coming in. My wife is sometimes complaining about, but we keep a spray bottle by the door to spray down all packages. And we're doing the same in our biobanking facility too. They're used to dealing with blood samples that may be contaminated with hepatitis and HIV. That's old hat to them. But now the risk is not from what's inside the packages, but what's on the outside. So again, they've started making sure all packages are sprayed down before they come into the biobank.
Yes, absolutely.
So, I think it is very, very, very sensible to be using sanitizer and doing hand washing. Hand washing, you don't have to worry about the supply of soap or things like that. Like you might have to do with sanitizer. So hand washing is very, very easy. The other thing is the use of masks. I know many of the health authorities in the world said that masks weren't going to be all that helpful. And it turns out that they were probably wrong, and masks are very helpful. They're more helpful in preventing you from contaminating other people than protecting you from the contamination from other people. So I think wearing masks is going to be vital. Certainly in the hospitals, they're making an effort to get good N95 masks. But even these cloth masks people are using at home are probably useful. And so, I came home from the hospital the other night, and in the hospital we're all wearing masks. All the hospital staff and the patients are all wearing masks now. And so I came out of the hospital, got on my bike and cycled home before I realized I still had my mask on. And so I think that's the way of the future for the next couple of years, that we're all going to be masked rangers. And so my advice is get used to it. It also helps if you got a mask on, it keeps you from touching your nose and your mouth and things. It gives you sort of pause when you do that. So wearing masks and frequent hand washing are going to be good.
Great, good advice. And I just want to invite anybody to ask a question. Feel free to put it in the chat at any time. There is one now that Dr. Ritchie, I'm not sure if you can see them, but I'll read it out for everybody. Is there a better way to get family members access? Oops, he disappeared. Sorry. Is there a better way to get family members access to others' files, especially families who live in different provinces? In particular,
That's my question.
yes, her father developed the symptoms for years, never tested, but clearly has attacks are mimics of mine. I actually have a multi-generational knowledge, as my great uncle had similar problems. She asks because both my father and I would be, and she would be willing for genetic sequencing.
Yeah, yes. As I mentioned, we're working through that now and hoping to change that paradigm. What I didn't understand until the last month or so was that if I send DNA on a patient to get it looked at for instance, the factor 12 mutation, they actually do full genome sequencing, but they only report the data on the factor 12. And we can request the raw data and search for the other mutations ourselves. So I'm trying to figure out, and hopefully we'll be able to make some progress this week on how we can actually do that. And once it's done in a couple of centers, I think you'll find it spreads out to the rest of the country. So I think there is a mechanism. I think Canada really needs to get on board with full genome sequencing and find imaginative ways like that to do it. I think it's important. And my feeling, I think most of the arguments against it are bogus. There's certainly a financial benefit in not looking at individual genes, which are more expensive, but in fact in doing full genome sequencing. So all I can say is stay tuned. I know in Saskatchewan, they're trying to get organized around angioedema treatment, but because the knowledge is not there yet. It's been a little bit hard to do, but I think it will come. And I'm in contact with the Saskatoon and Regina treaters, and they often will call me to see what we can do. And I think the answers I'll be giving them soon will be that we should be doing full genome sequencing, and I'll tell them how to do that. So stay tuned. We're close.
Okay.
Another question says, are HAE patients supposed to be an immunodeficient like diabetes patients? And it looks like Catherine touched on that. No, I don't think you need to be immunodeficient with diabetes to have HAE. I myself have HAE, and I neither have diabetes nor MRC immunodeficient.
So hereditary angioedema, because it affects the C1 inhibitor, and C1 is an inhibitor of complement pathway, and complement pathway is part of the immune system. It's been considered an immunodeficiency, but people aren't immunodeficiency in the typical sense of getting infections. So although it's sort of categorized as an immunodeficiency, I don't think you should necessarily consider it that. Diabetes is interesting in that the type 1 diabetes that we see in kids and young people is autoimmune, in which the person's body makes antibodies and an immune response to their own insulin and their insulin-producing tissues in the pancreas. So that is an autoimmune disorder, and autoimmune disorders do run along with immunodeficiency. So there is a connection there. In addition, we know that the people most susceptible to COVID-19, who seem to get the most severe disease, tend to be elderly. Many of you will have been following the fact that many of the elder care homes have had outbreaks that have killed off many, if not most, of the people staying there. So it's a huge problem. And the common thing about older people is that as you get older, your immune system gets old along with you. And once you're over 60, which means people like me, I'm 65 now, that our immune systems are starting to tail off and are not so good. And that's at least one of the factors we think is responsible for the high fatality rate in older folks. Also, people with diabetes and high blood pressure are particularly at risk. We think that's due to their underlying disease, but we don't know if it's even possible that it's due to some of the treatments we're using, whether people on some types of diabetic treatments actually might be at higher risk than others. So there's so much we don't know about this virus, and we're scrambling to try and find all these things as quickly as possible. But I think the bottom line is HAE is classified as an immunodeficiency, but really isn't one. And there's no particular association with diabetes necessarily. But if you do have diabetes, that's an added reason for you to try and avoid getting COVID-19.
There's a couple of other questions. If I have HAE and MGUS, I'm not familiar with that, am I more at risk for COVID?
The simple answer is no. MGUS, monoclonal gammopathy of unknown significance, is a blood disorder in which people produce too much of one type of antibody and it suppresses the other antibodies. So those people are a bit immunosuppressed, and that will give an added risk from COVID-19, but it's not related to the underlying angioedema.
Okay. And the next question is it possible in Alberta to pay for a private company to do full genome sequencing and get the results sent to your HAE doctor?
The answer to that is yes. And I have a thumb drive that I carry around in my pocket with someone's full genome sequence on it. And, you know, I looked at it and I wasn't able to find any mutations, but the tools for assessing the genome are changing all the time. There is a company, an American company, actually it's a a Chinese company with an American office that's doing the cheapest sequencing that I know of at $600 US. But when they give you your results, they give you them as a download from a website, and that's only available for a month or so. And after that, they scrub all the data. And I don't know why they do that. I think that in the future, really, what we need is not just the genome sequence. We need somebody to make a business out of managing that sequence.
Mm-hmm.
So as our knowledge of genomics grows, what we all really want is to have somebody looking at our sequence to see if any of the new findings apply to our DNA. And so there's a business model that's been proposed, and I think that's really going to be the way of the future, in which you might get your full genome sequence for free, just like you might get a cell phone for free. But then to make use of it, as you do with the cell phone, you pay for a subscription. In which case, you know, for maybe $100 a month, the company that has your full genome sequence will search that sequence, you know, on a weekly basis to see if any of the new findings in the last week apply to you.
Right.
So again, that infrastructure is not set up yet. People aren't sure about how to do that, but they're scrambling very fast to try and get that in place.
Okay.
Certainly in the UK, the UK is way, way, way ahead of the US and the rest of the world in that they've embraced this whole genome sequencing and model of how to help people. And much of that is due to the chair of medicine at Oxford, a guy named Sir John Bell. He's been knighted at 2 different levels now. And John Bell actually grew up about a kilometer from me in Edmonton, and we used to go drinking together. So hard for me to imagine him now being Sir John Bell, but he's pushed very hard in the UK. The Americans have come up with a project to do 1 million genome sequences now to try and figure out what a normal sequence looks like and what's statistically acceptable within genome sequencing. And they chose sites about a year ago, and they just got off the ground in December of 2019. In the meantime, the Brits had already done 100,000 and were also trying to do their own million sequences. So I think that's all going to happen. And we'll know what a normal genome looks like, and we'll soon have the ability to recheck those sequences on a regular basis.
Right. Awesome. We have one more question that I can see, but again, if anybody has anything to ask, feel free to put it in the comments. And the final one is, in case of COVID-19 infection, do you think treating attacks with icatibant could have an additional benefit over Berinert?
Yeah, and I think that's an area of research that, as I mentioned previously, I just heard about yesterday, that the icatibant may block the development of the edema in the lungs that causes such severe disease leading to death. So, but C1 inhibitor may well do the same thing. So we don't really know just yet. I think icatibant is probably a better approach, and I think Takhzyro it may be even better than that. So I can't say for sure, and I think those studies need to be done. My intention on Monday morning is to phone Takeda and see if we can get involved with the Takhzyro studies in COVID-19 patients.
Right. There is actually another question in the comments. Can an HAE patient with controlled hypertension donate blood on a regular basis? Will there be a chance of having unknown antigens of different diseases in other bloods due to having regular injection?
Yeah, those are interesting questions. Once you're taking medications regularly, Canadian Blood Services doesn't want your blood, because if you donate your blood and there's some of those medications in your blood, it might end up being given to somebody who's allergic to those medications, and that would be a big disaster. So anyone on chronic medical medications is discouraged from giving blood. As well, people who have received poor blood products, such as a C1 inhibitor, are discouraged from giving blood too. So if you're on a drug for your hypertension, you're probably going to be excluded. And if you've been receiving Berinert or other poor blood products, you're going to be excluded. And so I think the answer is no. You won't be able to give blood, or shouldn't try to give blood. And I don't, you know, if somebody is going to try and purify your C1 inhibitor out of your blood and you've got a mutated one, that's probably not a good thing either. So, you know, there's many reasons why you might not be a great blood donor.
Okay. I think that is it, unless anybody else has any questions. So I think that is it. I think that is to wrap it up. Unless anyone, no, final. Oh, Catherine, you have one more question?
Sorry. Yeah, it's kind of a bit more of a personal question, admittedly, but okay, so as Dr. Bruce Ritchie knows from my own personal notes, that unfortunately I had to go on painkillers for a lot of different other reasons for another condition, but because I was on painkillers, I ended up no longer having so many angioedema attacks. And now my concern is I'm actually going to be decreasing, hopefully within the next several months, these painkillers. So there's a chance I might see a resurgence of these angioedema attacks. So I'm just wondering if there's anything I should do to try and prepare for that.
So the short answer is I don't know.
That's what I thought. Well, you'll see me at the hospital either way.
Yeah, I haven't seen that in anyone else where the painkillers decrease the angioedema attacks. I could imagine that, you know.
I think it's masking it. That's what I think it's doing. I think it's honestly masking the angioedema, and so it's hard for me to tell. Yeah,
I know when you're in chronic pain, you're also anxious, and anxiety predisposes you to angioedema. So there's probably a connection there as well. So decreasing them, as long as you're able to find a way to deal with the pain, you know, maybe a non-pharmacologic way to deal with the pain, that I would hope would help with the angioedema as well.
Okay.
Whether it's, you know, meditation or other things like that.
Well, I ended up finding out that I guess serotonin, I guess I'm not really allowed to take serotonin because apparently it was driving me crazy. So that actually is why my mannerisms may be a little different even to you, Dr. Bruce Ritchie, is I went and saw a psychiatrist and she went and changed all my medication. So I think the anxiety portion has been lowered significantly.
That's great news.
Okay. I think that is about it to wrap it up. I want to thank you, Dr. Ritchie, for joining us and providing all your questions and explanations. We very much appreciate it. And thank you everyone for spending your morning with us. That is fantastic to have such a lot of us coming together, and it's a wonder we have all these technologies. We're lucky to have it. So thank you, and thank you for the panelists and Heather for taking time today. We all appreciate it. So if you have any other questions, you can email me, and I think everybody has my email by now. But I think that is it. I think we can shut it down. So thank you very much.
Okay, bye-bye, everyone.
Thank you, everybody. Thank you, Dr. Ritchie.
Bye.
Thank you.